Hi guys, welcome again to Intellect Medigos, where learning is made easy. I'm Dr. Chirag Madan, working as an intensivist at Apollo Hospital, New Delhi. In this video, we are going to discuss about the auscultation part of the respiratory system. If you talk about the examination, the first thing is obviously the inspection. Second, palpation. Third, percussion, and then comes the auscultation. But this auscultation is very important, all because nowadays many clinicians they are relying more on the investigation part, getting the ABGs, X-rays or HRCT. But uh, what I think is examination is much more important than the investigation. Obviously you need investigation to rule out, to make a diagnosis, but the first and foremost thing is to get a good examination of a patient. So for that you need to know the breath sounds, what are the normal, what are the abnormal, how are they different from each other, and how they are actually heard. So in this video I will tell you about the differences, the characteristics, and how they are heard. And I would suggest you to use headphones to hear those voices or the breath sounds. Okay, so let's begin. So, first and foremost, whenever we talk about the breath sounds, we categorize it into either normal breath sounds and abnormal or adventitious breath sound. In normal, there are three sounds. First, it is vesicular breath sounds. Second, bronchovesicular, and third is bronchial. Whereas, if you talk about the adventitious, there are crackles. Second, wheeze. Third, rhonchi. Fourth, stridor, and fifth, pleural rub. So these are the basic and the main adventitious or the abnormal breath sounds. Now, first of all, you need to hear it, how it is heard, and then I'll describe the characteristics of each and every breath sound. So starting with the first one, that is a vesicular breath sound. This is how it is heard. Now, as you have all heard about the sound, the name says vesicular. Vesicles suggest alveoli, but this is a misnomer or a misleading term. These breath sounds are not generated or initiated inside the alveoli, right? So, and these are vesicular breath sounds are present majority of the lung fields. Now, coming on to the characteristics of these, first and foremost is it is very soft. Second, it is low pitched, as you have heard. Third, the inspiratory phase is much longer than the expiratory, because expiratory is a passive process and the sounds which are produced are because of the turbulence. So that is the reason the expiratory phase is less if you talk about the vesicular breath sounds. And fourth is there is no gap between the inspiratory and the expiratory phase. So these are the four important characteristics of vesicular breath sounds. Now, coming on to the next one, that is bronchial breath sound. This is how it is heard. These bronchial breath sounds are, first of all, as you have heard, are loud. Second, high pitch, and the expiratory phase is longer than the inspiratory. And the fourth is there is a gap between the inspiratory and the expiratory phase. And that is the difference between these two, the vesicular and the bronchial. Coming on to the third one. The third is bronchovesicular, which is heard mainly at the membrane, right? And this is how it is heard, first of all. Now, this breath sound, bronchovesicular, is intermediate to bronchial and vesicular. So the pitch and the duration is intermediate, and the inspiratory and expiratory are of equal intensity and equal duration, right? But if the bronchial or bronchiovesicular is heard over the other regions of the lung, right, or the other lung fields, then there is a pathology. These pathology you can remember with the 4C. First of all, there could be collapse. Second, there could be consolidation, that means pneumonia. Third, there could be cancer or carcinoma, bronchogenic carcinoma. And fourth, there could be a cavity. So these are the four pathology where if you auscultate and if you are hearing a bronchial sounds or bronchiovesicular, then this suggests there is one of these pathologies. Now, coming on to the other, that is the adventitious or abnormal breath sounds. The first is crackles. This is how it is heard. Now, as you have heard the crackles, this is like a cellophane paper being crumpled, or a tissue paper, or a paper, just a paper being crumpled. So this is like a bubbling sound, right? Now this is a non-musical and a non-continuous sound, and it is mainly categorized as fine crackles or a coarse crackle based on the intensity, the pitch, the duration, and depending on the whether there is a positional change or not, whether it is settled by the coughing or not. So it is categorized in these two, fine or a coarse crackle. So let's hear the fine and the coarse differently. Now this crackling sound is because of the secretions in the airway, or it could be due to the explosive opening of the collapsed airway. So there are both the hypotheses, both the theories. Secretions or collections inside the airways, the small and the medium airways, as well as the rapid or the explosive opening of a collapsed segment, right? Now coming on to the causes of crackles. There could be pulmonary edema. Second, CHF, that is congestive heart failure. Third, in cases of consolidation. And fourth, COPD. So these are the main causes where you can get a crackling sound. Now coming on to the next one, which is a wheeze. This is how it is heard. This wheezing sound is like a whistling sound. So this is musical in nature and is continuous and is heard mainly in the expiratory phase, but can be heard over in the inspiratory phase as well, right? Now this happens because of the passage of air through a narrowed lumen, right, which occurs because of the constriction of the airway. So the causes are mainly the COPD and the asthma, right? And this wheeze is a high pitch. Now coming on to the next one, which is the rhonchi, the next breath sound. This is how it is heard. As you have heard, rhonchi and wheeze are almost the similar. The only difference is about the pitch. The rhonchi are having a low pitch. That's it. Everything is same. The causes, the pathology, everything is same. Now coming on to the next one, which is the stridor. The stridor is musical sound and loud, high pitched, and this is produced mainly because of the obstruction in the upper airway tract, right? Now if this stridor occurs during inspiratory phase, that suggests extrathoracic lesion. Example, laryngomalacia or vocal cord lesions. Whereas if it occurs in the expiratory phase, that suggests intrathoracic lesion. Example, bronchomalacia or tracheomalacia or any external compression. But if it occurs in both the phases, that suggests there is a fixed obstruction, like a stenosis, tracheal stenosis. So this is all about the stridor. Now coming on to the next and the last one, that is pleural rub. This is how it is heard. This pleural rub is non-musical and is present in both the phases, inspiratory and expiratory, and this is leathery in character, as you have heard. And the reason for this pleural rub is mainly because of the inflamed pleura which are rubbing against each other, right? And these are usually associated with pleuritic chest pain or local tenderness. So these are the basic and the main lung sounds or the breath sounds. I hope you have liked this video, and kindly hit the like button if so, and share with your friends and colleagues who needs this. All the medicos, the interns, the JRs, the clinicians, the nursing staff, the technicians, everyone, right, who needs this, who wants to learn about this auscultation. And do not forget to subscribe this channel for the latest updates of my video. Thank you so much guys. Love you. Take care. Bye bye.